of the muscle, of the delta shape muscle, and the part of the trapezium muscle also change in their position and functioning. So all of this contributes to a biomechanical disorder, and the pattern becomes atypical. Central nervous system can also be affected in such patients, and now a lot of research are conducted. Almost all the treatments like X-ray therapy, surgery, medical therapy affect the brain, and according to recent papers, it was shown that patients have a change in metabolites in their central nervous system. They have some microstructural changes in the white matter of their brain, even 10 years after the surgery, and there are some major changes in the functioning of the brain. As well, the density of the gray matter of the brain changes, especially in the front area. The cortex of brain changes, and it can be tracked even 5 years after the surgery. So the etiology of impairment is multifaceted, and before it was believed that only adjuvant therapy is the main reason for brain lesions, and there was a theory titled chemobrain, and it was told in this theory that chemicals get into the brain and cause changes. It was proved that oxidation of DNA can lead to degeneration after treatment, and the structure of DNA in the central nervous system can lead to apoptosis of neurons. Neurotransmitters also change, and the immune system is affected. Cytokines, interleukin 6 and 8 are generated, but other research are now being conducted, and it has been proved that other treatment methods also affect the central nervous system quite negatively. It is proved that X-ray therapy affects DNA, and chemotherapy as well. X-ray contributes to aging of the brain, and about 20 to 30 patients with breast cancer had observed some decrease of their cognitive abilities. It is believed that it is the tumor that affects them, and there are some anti-inflammation cytokines, and these cytokines contribute to the deficiency in DNA regeneration. So this hypothesis is now under argument, is the subject of argument. So the very fact of the oncological disease, the processes that lead to this disease, in general, cause a central nervous system disorder. And a new term, a new theory has recently emerged. This is cognitive disorder, like cancer-related cognitive disorder. Nowadays, we don't say that it has to do with treatment, but with cancer itself. Of course, cognitive changes were detected a long time ago, in the beginning of 1980s. It was shown that up to 80% of patients have cognitive function disorders after mastectomy. They process information slower, their memory decreases as well, and all these changes can be present for a long time. And of course, it affects the quality of life and work capacity of such women to a big extent. Cerebral vascular disorders, of course, first of all, those are the disorders in the cerebral basilar system. When patients have spasms of their musculus scalenus, and subclavicular arteries are affected due to their compression, and of course this requires neurological approach. Cerebrovascular disorders are also caused by the influence of chemicals and X-ray treatment. And clinically, this is statico-locomotory manifestations. These changes are being studied, and there are a lot of laboratory tests showing and equipment showing that the blood flow in subclavicular arteries is slowed down, and the venous drainage is also decreased. It was proved that the stem structures of the brain are also involved in this process. I would like to talk about the data of my Moscow colleagues. They assessed a group of 80 patients, and these patients had complaints in most cases for their headache in the back of their head. They suffered from dizziness, disorder of balance when walking, loss of consciousness, decrease of their memory, and the neurologist said that it was a lot of science, and we performed our own studies, and later on we will share it with you. Psychological and emotional disorders and the decrease in the quality of life is another manifestation. A lot of patients suffer from a decrease in their quality of life. The higher the level of edema, the lower is the depression and the quality of life. The level of depression decreases with time, and pain syndrome also contributes to the severity of depression. Paresis and edema, the stronger they are, the deeper is the patient's depression. 1 in 4 women have a clinical picture of depression, and depression it also affects the woman's capability for rehabilitation. So we have to treat it very seriously, because sometimes it's just impossible to perform rehabilitation in women with high levels of depression. So speaking about anxiety, after the surgery, right after the surgery, the level of anxiety is not very high. But when the patient sees the consequences of her operation, when she starts coming back to her routines, the level of her anxiety grows. And the higher the edema, the stronger the edema, the higher is the level of her anxiety. Reactive anxiety also is connected to neurological manifestations. The quality of life decreases at all stages of treatment. First and foremost, those are the consequences of surgical intervention. It's a serious surgery. The functions of the upper limb suffer, and patients have fear of a lethal disease, their tolerance towards stress increases, and very often they have problems in their families, problems in the relationship with their partners, and their self-esteem as well drops. Speaking about the quality of life, it's a similar trend. The longer time passes after the surgery, the lower is the quality of life of such patients. Like a short time after, the woman is still expecting some improvements, but afterwards her expectations go away, and women present with despair. So this is quite a wide range of neurological manifestations, and they lead to well, we say that we can detect, we can treat this oncological disorder, but as for rehabilitation, it's not always that we can manage. In many cases, the results of rehabilitation do not satisfy neither the doctor nor the patient, and it's a challenge that we are facing, and we need to treat it together using the multidisciplinary approach, and it requires a lot of interventions on the part of different specialists. In general, it must be said that when we speak about post-mastectomy syndrome, we have to understand that it is very multifaceted. It leads to a lot of pathogenetic consequences. Those are the disorders on part of different systems, the lymphatic system, the cardiovascular system. As well, there can be some genetic predisposition for this condition. And all this leads to the conclusion that besides the seen part, there is the hidden part of the iceberg. There are some disorders on the level of neurological networks, neural networks, and all that is about neurodegeneration. And this neurodegeneration hampers rehabilitation. This requires a specific and neuroprotective approach. So neurological approach and psychiatric and psychological approach should be included in our multidisciplinary treatment. This way we will be able to return 1.5 million of women who suffer from this syndrome in our country. And well, 10 years ago in Moscow, guidelines were published about the role of neurologists in examining such patients, and a room in clinics, a special room with neurologists was established. So every patient who have had their breast removed are supposed to see a neurologist. Now this program um, is not working fully, so it's just in Moscow. So our group tried to launch a social project, and we announced about this project on the Leaders of Russia platform, web platform. And to conclude, I have to say that it's a very complicated problem, and we have to treat not the disease but a patient, and this treatment should be individualized, should be personalized, and a doctor should be like an artist, perceiving each patient as a unique human being. Now, I would like to give the floor to Irina Tuzankina from Yekaterinburg, and her presentation will be about genetics and lymphedema.
Good afternoon, dear colleagues. Can you hear me? Yes, we can. Thank you. Yeah, we had some technical problems, but obviously everything is fine at the moment. Can you see my presentation? I've just shared the screen. Okay, I'll start the presentation. First of all, thank you very much for the invitation to participate in this session, this roundtable, and the Congress in general is really very relevant at the moment. From the point of view of natural science, from the natural outlook at life in general, and it is not by accident that in my presentation I will focus significantly on genetics, because knowledge that is available today prove that everything in an organism, all pathologies, all diseases, all possible complications, all this depends on programs that are hardwired at birth, and everything, all these programs are realized via immune mechanisms. And this situation with COVID that we are witnessing today also made us pay our attention to the fact that immune mechanisms implement and start these problems, and these mechanisms are defined by genes that are activated at the moment, and as a result, neuro and immune and endocrine systems are activated, and if just one component of this general system is out of order, then it will influence the whole system. And as we all know, everything is defined by intracellular and intrareceptoral interaction. And what is peptides? Actually, the peptides as the result of activated genes that are active at the moment. So today, I'm going to talk about these things. I probably need some technical support because I cannot scroll my presentation. So today's paradigm reflects the current problem. And we are just about a new breakthrough, just about the new stage of knowledge. Movement in medicine, it's movement towards personalization. We've just heard very right words that personalization is the main achievement that guarantees success in each and every case. Pathologies are understood differently now. What was considered to be one disease is now classified in many different categories as different diseases. And they turned out to be absolutely different. And genetics managed to prove different origins of these diseases. On the other hand, diseases that seem to be different turned out to be different manifestations of the same disease. So, in fact, the classical understanding and knowledge has changed about, this is the knowledge about diagnostics, first of all. And today we are looking for new methods and for new approaches of diagnostics that will bring us closer to the success. Therapeutical means are also necessary, and interdisciplinary integration and cooperation is the prerequisite for success. Obviously, mistakes are inevitable. Here you can see COVID virus, the today's challenge. And I tried to assess this situation from the viewpoint of different sciences. So in order for us to get knowledge which is true, we have to cooperate all together. And first of all, we think about biology, immunology, because it is my molecules that define the physical and pathological implementation of different processes. Then, of course, genetics, and it's not only about genomes, but also about its outcomes. And in order to understand what we have as the result, what is going on with an organism, of course, we should have a lot of experts in mathematics and chemistry and bioinformatics. And all this knowledge is available in our country. Moreover, since January and June, after 6 months in January, we will change the classification of diseases. There are immune deficits. They are 430, and 60% of all other diseases have another additional description, immunopathogenesis, because diagnostics and treatment efficiency and the use of different molecules, all these components are defined by immune mechanisms and probable impairment of their mutual functioning. And of course, immune process is understood differently nowadays. Before that, immunity was considered and understood as a protection against diseases. Today, we understand it as a system that helps us to support homeostasis. So that is why today it has more functions, and pathogenetic significance of these mechanisms and of immunology has changed, and our understanding has changed. And in this register, there is immune deficiency, primary immune deficiency, inherited or inborn errors of immunity, or as they were called before, primary, And they are more than 500, and we have more than 500 genes, but there are more than 10,000 genes at all that are involved in these processes. So we have a lot of things to do and to understand, and they define different immune deficiencies. And there are also secondary immune deficiencies when central or peripheral organs of immune system are disrupted and they cannot regulate immune function in an organism. And there are also immune-dependent diseases. There are also autoimmune diseases, autoinflammatory diseases, absolutely new class of diseases. You know, very good example, for example, cytokine storm. This is autoinflammatory process, inflammations, allergies, inflammatory processes, etc. And in January 2020, a resolution was signed. That was a global resolution from the Jeffrey Model Centers Network. And this is a document that proves that at least 2% of the population have inborn errors of immune system, and they define our life, our physical and pathological possibilities for the rest of our lives. Today, primary immune deficiencies are diseases that develop because of the inborn immune impairments or because of genetic defects that may impair the cascade of immune reactions, immune competent cells function, reparation, impairment, morphological and functional disorders. All these are disorders and impairments are genetically determined. And all these disorders and impairments can be also transformed into severe processes. Like, for example, as for COVID, there are dozens of new descriptions of secondary diseases, and our French colleague, Professor Casanova from France, proved that these are the inborn errors of immunity about the genes that correct the work of receptors to interleukins. And those who have these inborn defects, they have this secondary COVID-19 disease or secondary tumors, and the same story about it. And if, for example, we have a primary immune deficiency and we have this diagnosis after tumor has already developed, it's already too late because we've lost already a lot of opportunity to help a patient. And still, we had a possibility to interfere and to prescribe pathogenic therapy to avoid a lethal outcome. And primary immune deficiencies, at least in 30% of cases, are manifested in different tumors or autoimmune diseases or immune inflammatory diseases. How all this is organized? Genes are mutated, so these are molecular and genetic impairments. So this is a deviation from the norm, and as a result, different disorders, impairments may be formed, like, for example, impairments of lymphoid tissue, for example, because it is, of course, definitely a part of the immune system, and it entails immune-related diseases. And immunity is a complex of reaction to support homeostasis of macromolecules, therefore inborn errors of immunity. So what is immunology and primary immunodeficiencies? In fact, the development of immunology reflects the history of this notion. You can see that in the 60s, the term immune deficiency appeared for the first time, and in 1968, the first gene of immune deficiency appeared. In 1999, 13 years later, there were 74 diseases included in the register, and in 2006, there were already 128 diseases. Today, we have almost 500 diseases and almost 500 known genes that can verify this or that variant of a disease. Today, primary immune deficiencies are not rare and not fatal, and adequate therapy may stabilize patient's condition in most of the cases. Doctors are often not careful about these pathologies, and that comes as no secret that quite often medical students are even not taught this fact, and this may increase the mortality rate. And sadly, 25% of these patients die at very early, at the very first year of life, others before 5 years of age. However, there is also a group of patients that may live quite long lives. They may have also different diagnoses that are not related to immune deficiency for the rest of their lives. So diseases that are diagnosed in these patients is the consequence of this primary immune deficiency, and sometimes it would be enough just to prescribe the right molecule to treat the system, to improve this integrated, very complex, multifaceted system. And those who die during the first year of life have significant genetic impairments, and they have these combined impairments. And here we have to pay attention to lymphopenia, to hyperplasia, and respiration impairment after any medical intervention. And disorders are often found in these infants, and often inflammatory processes do not have infectious improvements, and if they have, then that is mycosis. And so if you see mycosis, then most probably you can be sure that it is immune deficiency. So today these 500 immune deficiencies are classified and categorized into 10 groups. We have made this classification. You can find it in a medical journal. It is also published on our site of immunologists. And of course, there is no possibility to keep all these diseases in mind, especially taking into consideration that each and every patient is unique. Here you can see the example of this classification. This is a group of combined immune deficiencies. To the left, you can see the name of a syndrome, and to the right, I just emphasized those that are connected with lymph. So you can see, for example, lymph system impairment, vasculitis, lymphomas, vasculitis, and other syndromes connected with it, leukemia, and very different diseases, inborn abnormalities, not only abnormality of thymus, the main organ of the immune system, but also abnormalities of lymphatic vessels, of heart, of other organs. Here is the list of other diseases. You can see that this list is really very long. A lot of different diseases connected with lymph impairment, different examples that are connected with different syndromes, like, for example, Hanukkah Syndrome, that I'm going to show at the moment. This is a girl, and normally these are surgeons' patients. Target therapy today that neutralizes the signal pathways of these pathologies. So that was a kind of crossroads of our interests. So we have a group of patients with inborn defects of lymphatic systems, lymphedema. We have 30 patients that we follow up. Some of them get treatment, get therapy, immune intermediate, and this therapy helps to hamper the development of the disease. Here you can see that on the right side of this girl, there are lymphedema, and when we studied the genetics of this girl, we found out 4 mutant genes And 3 of these genes were already described in foreign publications. And the 3rd group of a primary immune deficiency with immune dysregulation, these are the syndromes that are not of infectious nature. And here lymphoproliferation comes the first on this stage. And here you can see different lymphomas. So you can see that these diseases are really numerous. There are also different vasculopathies, different family diseases. But of course, we do understand that many diseases, in fact, are autoimmune inflammatory syndromes. And as I've already mentioned, these diseases are very numerous nowadays, and a lot of impairments and defects. In our regional register for Sverdlovskaya region, there are 642 patients. 481 are alive among them. Sadly, but importantly, that 102 cases were detected after death. And if we have a possibility to have a reconstructive interference while patients are alive, when stem cells are reconstructed, and by the way, this was done in the center named after Raisa Gorbachova. And even rare diseases, 17 cases across the globe are observed in our center. We also provide them with replacement therapy, target therapy, and we provide these therapies to many patients. As for post-mortem analysis, then we found out that in the first year of life, approximately 60% of patients die who had this or that primary immune deficiencies that were not verified during their lives. And the autopsy proved sepsis, for example, or sepsis generalized infection, tuberculosis, pneumonias, other diseases, and those were caused by primary immune deficiencies, non-verified. The results are already published, and you will have a chance to read all this information. We have already got 15 patents for these solutions, and we also have a visual database because there are no similar patients at all. For example, even within one family, here you can see that a baby boy died at the age of 8 months, a girl today is 3 years and a half, and the mother, who was examined when she was 34, also has a deletion of the 32nd chromosome. The dad doesn't have this deletion, and one of the girls has an inborn heart disorder, and this is a very significant impairment. So family medical history is really very important, and unfortunately quite often our doctors do not have this possibility to get this medical history. However, this should be the main tool. Another example, mother had deletion of X chromosome, and the father had the deletion of the 22nd chromosome, and they had children with different deletions. Both girls inherited this deletion. The first girl died, and she was diagnosed with sepsis and inborn heart disorder. The second girl that had the deletion of the 22nd chromosome, this is a girl to the left. She was operated on, she had a surgery on heart, And this girl in the middle, she has both deletions from her father and from mother. So she has manifestations of oligophrenia. So here I would like to end my presentation, and I would like to invite you for cooperation. It is not by accident that after operations, after cancers, different complications may occur, different complications that may impair lymphatic vessels, for example, and other impairments. This can be caused by inborn immune system deficiencies and any inborn genetical pathology has different periods when it is manifested or not manifested, and the time when it will be manifested for the first time. And for the first time, it can be manifested at any age, in adulthood, in senior age, etc. And these patients of different ages should be examined really very carefully. They should be examined to check different possible genetic defects that are often neglected or ignored even in medical education. But today we are aware of these factors, and we should keep it in mind, and we should use this knowledge. And here you can see a group of our colleagues who work in our Center of Clinical Immunology. We have been working, I'm in our center for 35 years already, and thanks to these people and my colleagues, this work is possible. Thank you very much indeed for your attention. Thank you very much. Yes, this is a black box that you have just talked about, and this black box that we are going to open step by step, because of course immune diseases, that's a new era that we usher in. Obviously, we are going to face more and more of these diseases, and with more knowledge, with more opportunities, of course, definitely we will discover more genes, and we will have more information about primary and secondary lymphedema that often occurs after post-mastectomy, and probably in many of these patients, there will be some genetic reasons for these diseases, and we hope to continue our cooperation with this center, and hopefully together we will make breakthrough. Thank you very much. Thank you. And now the floor is given to another colleague of ours, to Varvara Krasnikova from the center, National Research Center named after Almazov, and the presentation will be devoted to microcirculation and exercise algorithm in patients with post-mastectomy syndrome.
Good afternoon, dear colleagues. I would like to present, my presentation is about features of microcirculation and exercise algorithms in patients with post-mastectomy syndrome. And it has been mentioned that about 95 patients who have experienced mastectomy, who have experienced radical mastectomy, present with different manifestations of post-mastectomy syndrome, and it is known that exercise therapy is very important in its treatment. Nowadays, out of 42 patients, only 1/3 received this exercise treatment in hospital. Most part just received some recommendations in written format, and some just received this recommendation in oral format, while there were patients who did not receive any recommendations at all. So the awareness of patient is quite low, and their motivation level is also low. This is a problem not only here in Russia, but also in the US. There was a study of 700 women. It's only 1/4, 1 in 4 women followed the recommendations in the field of physical rehabilitation. The obligatory components of the programs of physical rehabilitation of women with post-mastectomy syndrome include awareness and exercise. The main means is exercise. So choosing exercises is always very important. Exercises are like medicines in therapy. It should be chosen individually, and it should be aimed at solving the particular problem. Of course, written recommendations for our patients do not comply with these requirements. However, it's better to do something than to do nothing at all. So what factors affect the choice of exercises and the level of physical load? First is the patient's tolerance to physical loads. It's the condition of their cardiac and pulmonary systems, their level of physical preparation. It's important to see if a patient has an edema, if the amplitude of movement is wide enough, if there are any biomechanical disorders, and if microcirculation is affected. We examine microcirculation in order to form personified programs of physical rehabilitation. We use laser Doppler flowmetry, and this way we can assess perfusion in different areas of the microcirculation bed. We compare the condition of patients at rest and after physical load. The blood flow is reduced in our patients when they are at rest, and they get higher after exercise. More than half of our patients have different disorders of microcirculation. First and foremost, this is microspastic type of disorder. In 14% of cases, there is this stagnation, and in some cases, there is spastic problems. 10 minutes after a load, blood flow should activate. However, in our patients, we observe inversion of these patients, and there is no hyperemia. Nutritive blood flow grows very slowly, and probably it has to do with the spasm of the precapillary sphincter after the physical load. Depending on the form of disorder, microcirculation disorder, we personify our sets of exercises. If it is a spastic form, we rule out all the exercises with static stress, and we prescribe dynamic exercises. in stagnation form, on the contrary, we try to give a lot of exercises with hands, arms, and legs up, so to decrease the load. And we also include drainage exercises such as shaking, and depending on if there is an edema, we also modify, we alternate the sets of exercises, and we give recommendations to women. We teach them to control their edema. We teach them to lift their extremities. We teach them to avoid prolonged stress, and to control their weight. We also prescribe them exercises with starting positions, with arms or legs up. We teach our patients to use compression garments, and use different devices such as rubber bands and expanders. If the amplitude in the shoulder joint is restricted, we also modify our sets of exercises. If there is mechanical limitation, then the active and passive amplitude is lower. If it's about functional problem, then the muscles are weaker, and we can use different techniques in these two types of disabilities. And if it's functional restriction, first we have to strengthen the muscles, and then the amplitude will become bigger. We give some exercises for motion control of the shoulder blade and mobilization of the spinal cord. Some patients present with biomechanical disorders. For example, shoulder blade can be misplaced. There can be hypertrophy of the trapezium-shaped muscle, and there can be functional scoliosis, especially in cases of lymphedema. In order to correct the biomechanical disorders, we train stabilizers of shoulder blade, and we include exercises stabilizing the trunk in order to improve the spinal column position and get rid of scoliosis. As has been mentioned, some patients present with the syndrome of upper aperture of the chest, which is also called the syndrome of anterior scalene muscle. Patients complain for pain, for dumb limbs, paresthesia, and we diagnose this symptom using special functional tests and some equipment. Rehabilitation in this case includes two stages. At first stage, we try to open the aperture. Muscles of the chest are trained, and at the second stage, we pass to stretching of this muscle. First and foremost, the scalene muscle. In polyneuropathy, balance exercises and power exercises have proved their use, and the same muscle can be trained differently. For example, if we need to train the anterior pronged muscle, we can use different starting positions, different devices, increasing the weight, and we solve the same task using different exercises. If there is an edema, it is better to have extremities lifted. If there is a spasm, on the contrary. Shoulder blade retractors can also be trained in different regimes. So I want to say that choice of exercises is similar to choice of drugs. And physical rehabilitation has to proceed from collection of anamnesis data, from some functional tests, and on the basis of this data you formulate your hypothesis, and then based on this hypothesis you create a sequence of exercises, and you don't have to say just like train your shoulder blade to a patient. You have to prescribe particular exercises with all the details, like which exercises, how many times a day, at what time, etc. And this is not all, because in working with patients we have to make progress in our treatment and control the efficiency. We have to check the hypothesis. Probably it was wrong. So efficiency should be controlled at all the stages. So Varvara Valerievna, thank you very much for your very detailed presentation. Of course, individualized, personalized approach is very fruitful. And when we proceed from evidence-based medicine in our choice of exercises and drugs, this is really trustworthy. And when we can justify our sets of exercises, this is a very correct approach. I think that feedback between the patient and the doctor is very important. Probably at some stage we will have some applications to enable this feedback in a modern form. And now we will pass to another presentation by Tatiana Alexandrovna Bukieva. She will speak about MRI in the assessment of the central nervous system in patients with post-mastectomy syndrome.
Good evening. Good evening, colleagues. So the subject of my presentation is MRI in the assessment of the central nervous system in patients with post-mastectomy syndrome. I'm an X-ray specialist and work in the department of the radiation diagnostics in Almazov Center. Today, we've already heard that post-mastectomy syndrome, in fact, is a combination of different syndromes of functional character after the radical treatment of breast cancer, and its frequency is from 25 to 90% in all patients after the radical treatment. Pathogenesis of post-mastectomy syndrome is quite complicated, and of course it is connected with local fibrosis and atrophic changes in post-operational zone, post-operational areas. These are also post-operational changes, post-radiation changes, and all these changes influence lymphatic system, may cause lymphedema. They also influence central nervous system and peripheral nervous system. So we are talking about acute pain, loss of sensitivity, loss of muscular force, but the central nervous system is also impaired. Quite often, Scalenos syndrome may develop, or vertebral basilar insufficiency, or different variants of chronic impairments of cerebral blood circulation. There may be different disorders and nervous system. It can be anxiety, depression in post-operation period. Of course, patients have different impairments of nervous system, and in this case, they should be diagnosed. And for this purpose, in our research, we've used the methodology of functional and diffusional MRI. Today, we've talked about clinical variants of post-mastectomy syndrome, and what is most widespread today is the so-called combined method, which includes all variants of possible impairments. This can be edema, neuropathetic component, cerebral component, different impairments of nervous system. The relevance of our research is caused by the fact that the quality of life deteriorates significantly, and this is not only because of the lymph drain, but also because of the impairments of the central and peripheral nervous system. A few words about methodologies that we've used in our research. Functional MRI is a modern methodology of neural visualization that is based on BELD mode, that is blood oxygenation level dependent. This methodology helps to define different areas of activation of the brain on the basis of hemodynamic changes. These hemodynamic changes may occur because of a stimulus or at rest. And functional MRI at rest is really widespread today. It allows to define functional coherence of different areas inside the brain that make neuronal networks at rest. Currently, in neurophysiology, it is believed that this structure is responsible for a wide spectrum of processes, both normal and abnormal. So it is important to examine functional state of the central nervous system in different pathologies that may influence the central nervous system. One of the most important network of rest is the so-called default network mode. This is the main network of rest that is involved in a lot of cognitive processes like memory, emotions, etc. And impairment of this system were detected in different research, in different disorders of CNS. For example, in particular, there were a lot of researches that prove that the brain in passive mode also works during pain syndrome. It is also very important in psychiatric impairments. Currently, it is believed that the change in this mode is a predictor of earlier cognitive impairments. And the key point is medial prefrontal cortex. And here on this slide, you can see normal function of this mode. And the bright red color shows you normal areas of the brain, of the passive functioning of the brain. You can see here prefrontal cortex and backwards cortex. With functional MRI, we assess and estimate different indicators, like, for example, activation volume areas that can be either positively or negatively connected. And on the basis of this, we also assess either positive or negative networks between different areas of the brain that are involved in the passive mode of the brain. After the functional MRI, we get the primary data that are expected to be post-processed. This processing is done with help of different methodologies for example, statistics methodology of independent components, and another method that is based on different interest zones. And for statistics processing, we use con program, free server program. This is software to process, analyze, and reconstruct the images with the restoration of activation zones in the cortex. And here you can see the normal activation in the passive mode with the use of method of analysis of independent components. So you can see that the red point color shows the normal activation. Also, you can show it like this with this is a post-processing MR data of the functional MRI of the passive mode. Red shows positive networks, blue shows negative networks between medial and prefrontal cortex and other areas of the brain. Moreover, we also use a diffusion and tensor MRI. This methodology is based on the proud movement of water molecules in the white matter of the brain, and the conducting pathways are represented by axons that are covered with a special coat, millennial coat. They are hydrophobic. That is why water molecules go along the pathways, and this is described as anisotropia. So with this methodology, we estimate this coefficient, and with this methodology, we can also assess microstructural impairments of the white matter. So these are the impairments that are not detected in other methodologies of MRI. And the methodology, this very methodology, is very widely used in studying the white matter, the geometry of pathways in different pathologies, and which plays a significant role in assessing the brain, both in norm and in pathological state. At first, we get the primary data, and after that, this data, with the help of different software, is reconstructed, is processed. This is a 3D reconstruction of the white matter tracts of the brain, and with the help of this reconstruction, we can see the integrity of pathways in the white matter. The purpose of this work is to assess the functional and diffusion tensor MRI in visualizing functioning of the brain. The purpose of this research is to develop a methodology of MRI and MRI semiotics. Patients with post-mastectomy syndrome, and finding the markers of brain impairments in order to define which particular structures are impaired, which functioning is impaired in patients with post-mastectomy syndrome. Then we will assess the results of working parts of the brain in order to define further rehabilitation activities. We will assess the dynamics at the backdrop of the treatment, and we will also assess the correlation with the use of MRI, DT MRI, and other research. Currently, this research examined 20 patients and 20 volunteers. The average age is 46. All patients were in post-operational period after mastectomy. Criteria was actually the post-mastectomy without cancers. Criteria that excluded possible volunteers or women are contraindications for MRI, tumors of the brain, different traumas of the brain, pregnancy, availability of mets or growing tumors and post-operational period. Besides MRI, of course, we collected the medical history and we made other research in order to get a complete understanding of what is going on with the patient. Neuropsychological research was also conducted, and we used different scales to assess the pain syndrome. We used the self-esteem score by Zhang, anxiety score by Spielberger-Hahn, and a questionnaire about the quality of life. The research was conducted on Siemens magnetron trial and the standard planes with the use of standard sequences T2 and T1, term and MP range. And then we made a diffusion MRI and functional MRI resting state. Post-processing was conducted with the Con software. Results. All patients show different clinical manifestations of post-mastectomy syndrome. You can see it on this slide. Most patients had edema, sensitivity was lost, paresthesis, muscular weakness, pain syndrome, headache, insomnia, dizziness, etc. Positive probes, positive tests were done in 60, was identified in 60% of patients. As for the results, there were changes in neuropsychological testing. 40% of patients had signs of depression, 50% had anxiety, and all patients said their quality of life has deteriorated. And finally, MRI resting state in patients with post-mastectomy syndrome showed that these patients changed their passive mode of brain, and positive networks, the number of positive networks have changed between medial and frontal cortex. That was changed in different areas of the brain, including cerebellum and other parts of the brain. There was functional reorganization of neuronal networks with the increase of negative networks in medial and prefrontal cortex and other structures of the brain. This slide shows that there are less positive networks. Here you can see that there are more blue or negative networks between different areas of the brain, between medial and prefrontal cortex and other areas of the central nervous system. Another variant of reconstruction also shows the prevalence of the blue or negative networks. And another variant of the three-dimensional reconstruction. And we can see here that again, that negative networks prevail. As for diffusion tensor MRI, we also witnessed changes in patients. There were also changes in different areas of the brain in, for example, medulla lobus, in corpus callosum, and in other parts of the brain. So what are the conclusions? As it has already been mentioned, the conference, rehabilitation is not satisfactory either for a patient or for a doctor, because first of all, they are aimed to correct the edema and they do not improve the state of the peripheral nervous system. And with the help of MRI, we can define structural changes in the brain in patients that are caused by different psychological impairments, and the quality of life and its deterioration requires a complex approach to solve the problem. As for further targets, that is to broaden the cohort of these patients in order to make more comparison and more statistics, and to compare it with other research and other statistics. And also in the future, we plan to assess the dynamics of these changes that were detected in MRI in patients during their rehabilitation period. Thank you very much indeed for your attention. Thank you very much, Tatiana Alexandrovna. Today you've just covered really very subtle approach, delicate approach to nervous system, because blood oxygen level dependent technology allows to define microhemodynamic changes in activation zone. And what it means actually the activity of the blood flow, because there are differences of magnetized and non-magnetized blood, magnetized or not magnetized with the oxygen. So this methodology helps us to assess hemodynamic metabolism. That is especially important in patients with subclinical impairments and disorders, when a patient does not goes to neurologist or to psychiatric, even though there are also some degenerative processes in place, and at the very beginning we still can influence this process, but if it is not examined, then this process becomes irreversible, and in this case the quality of life will deteriorate significantly, and the problems and complications will become even more numerous. There will be also problems from the viewpoint of neurology and psychology. And the next presentation as also will be by Albina Mansurova, who will describe the clinical picture of cognitive impairments, of quality of life in patients with post-mastectomy syndrome. And she has a larger cohort of patients. Today, we have analyzed more patients, but in fact, none of them had MRI procedure. So the floor is yours.
Good evening, dear colleagues, dear panel, and I will speak about the neurological, psycho-emotional, cognitive impairments and assessment of life quality in patients with post-mastectomy syndrome. The definition has already been given. I will just say that all patients have progressing complications such as lymphatic edema, pain syndrome, limited mobility in the shoulder joint, cerebral vascular disorders, psycho-emotional disorders, etc. We face all these symptoms. According to the World Health Organization, in 2020, 2.3 million of women worldwide were diagnosed with breast cancer. Breast cancer is the most frequent cancer in women in Russia, and the growth rate of this disease amounts to 1.97% over the period of the last 10 years. So the problem is very topical, and its topicality is growing, though preserving breast preserving operations, the amount of those is growing. Still, a lot of patients develop post-mastectomy syndrome, and the etiology of this syndrome has been studied, but not fully. The reasons of this syndrome are considered to be surgical impairment of nerves and lymph nodes in the axillary area, and our patients also have some psychological problems such as anxiety, depression, decrease of their sexual activity, and a general decrease in the quality of life. So our purpose of our work was to study the neurological, psycho-emotional, and cognitive disorders in women with this syndrome. We chose 45 patients who were operated 1 year ago, or more than 1 year ago, in the age from 25 to 50 years. and we ruled out metastasis and growth of tumors. We did not observe women with acute impairments of cerebral vascular circulation and other severe disorders. 26% received modern radical mastectomy, 17 had sectoral resection, 2 patients had subcutaneous mastectomy, and 10 patients were operated with reconstructive surgeries. Comprehensive treatment, it was in the case of 7 patients, chemotherapy in 32 cases, and 6 patients received a combination of different treatments. The stages of cancer, this is what you can see on the screen. So we had 23 patients with second stage of cancer. It's 2A stage. So what kinds of research did we use? We collected anamnesis, complaints of patients. We assessed the neurological status and neuropsychological status. We made some probes like Rothberg test. We checked their plexus, axillary plexus, and as well we check the activity of their trigger zones and perform such tests as the quality of life test S36 and a questionnaire of C3 questionnaire for oncological patients and some other questionnaires using different scales. And we also assess their pain using the Mac-Gilla scale. You can see that a lot of patients presented with headaches, sleep disorders, memory decrease, edema, pain in the area of their shoulder blade and shoulder joint, and limitation of mobility of their upper limbs. We assess the objective and neurological status of our patients. We started with a general exam of their muscles. 26 patients presented with hypertrophy of their trapezium-shaped muscle and delta-shaped muscles. Our patient said that edema of their upper limb was the major sign of their syndrome. 37 women spoke about it. As well, a lot of patients said that it was difficult for them to move their arm. They could not lift it higher than the horizontal position. And assessing the neurological status of the patients, we came to the conclusion that a lot of women, 39 women, suffered from lack of sensitivity of their skin. 40 patients suffered from paresis. The Royberg position instability was also a symptom in 25 patients, and hyperabduction test was positive for 31 patients. As well, we performed tensor algometry, finding the trigger points on the trapezium-shaped muscle and the anterior scalene muscle. And as well, we used an equipment when we were assessing this muscle impairments. We were using special equipment. One of the complications in post-mastectomy syndrome is the syndrome of upper aperture of the chest. It manifests itself in pains, edema, paresthesia, and the syndrome of vertebral-basilar insufficiency. We also assessed neuropsychological status of our patients. Here you can see the pain syndrome. So patients presented with slight and medium pains. Here you can see the results of the McGill questionnaire. 64.7 patients showed pains pains of this picking and nature. We used the Swilberg-Hanisch scale to assess the anxiety level of our patients. Here there is this table, showing their anxiety. We used Zung scale to assess depression for 20 patients, and here you can see that the average is yes, okay, so as well, we SF36 questionnaire was offered to patients, and 24 patients answered the questions. So you can see different indicators of physical functioning, role functioning, and these indicators are decreased. And it means that the post-mastectomy symptom affects life of patients to a large scale. Here you can see the results of the Aortic Questionnaire, and it also proves for a reduction, for a decrease in the quality of life of patients. Below is the FACT-G questionnaire, functional assessment of cancer therapy general, which also manifested a decrease. And the last scale that we used was the DASH scale. The average point was 79.6, which speaks for the impairment of the function of the upper extremity. Speaking about statistical data, we found correlation between the pronounced pain and the depression. As well, we revealed correlation between pain and general life, quality of life. The reverse relation is between the SF36 scale and the pain syndrome, and the SF36 and the DASH scale. And we make such conclusions that the term, like the time when the surgery was performed, does not affect the nature of the pain syndrome. These are the complications that affect the condition and the mood and the psycho-emotional conditions of women. And post-mastectomy pain syndrome does not go away on its own as the time goes by, and it requires professional treatment and rehabilitation. And all of our presentations have this like conclusion that if we form an algorithm of treatment of patients with post-mastectomy syndrome, we can affect their condition in a very positive way. Thank you very much, Albina Mansurovna, for your very detailed presentation, for your very detailed descriptions of the clinical picture. Of course, if we do not go into details, if we do not analyze their complaints, sometimes we can miss out on a lot of symptoms and manifestations. So clinically, you have to be very attentive, and I'm glad that you did this work. So now we will try to make some conclusions, like sum up our work that took quite a lot of hours. This was a very multifaceted approach. It was a real round table conference gathering different specialists, and we really managed to discuss different aspects, different approach, and we worked like a team, and we are now, I would say, on the threshold of creating an algorithm, an approach, a multi-pronged approach to rehabilitation of women that would satisfy both doctors and patients as well as their families, and it will give us an opportunity. Well, today we listened to a very interesting report, very interesting presentation in genetics, in surgical treatment. We heard that you can prevent edemas using microsurgical techniques, and we know that our central nervous system is affected, and we can assess the metabolism, the work of brain, knowing how periphetic or vegetative nervous system is affected. So really, I would like to thank everyone, all the participants and organizers, for these opportunities to fundamentally discuss this issue. And I think that for all of us, it will be motivation. Probably we will have more ideas and opportunities of cooperation. Thank you very much, Maria Lvovna. I agree with you, and I think that we have met our goals. We really made it possible that specialists from different fields have come together, and it was a real joint work of rehabilitologists, surgeons, neurologists, and other specialists. So I think that this is the most correct way. This is the most correct road on the way of elaborating the most efficient methods of both conservative and operative treatment of this disease. I thank all the speakers, all the doctors, all the specialists who have taken part in our session, and I hope for our further cooperation, our creative union that will help us achieve brilliant results. Thank you very much and see you next time.